It's time to wake to sleep with Sleep Science Today, where we learn to sleep well with your host, Andrew Colsky on UK Health Radio.
All right, welcome back to Sleep Science Today. We have another episode today. We're going to be talking about the relationship between cancer, sleep, and fatigue. My name is Andrew Colsky. I'm the host, and our guest today is Dr. Alexandria Muench. She is working specifically in this field and has done a lot of work with cancer and sleep issues. I know this is something important for a lot of folks, so I'm looking forward to the discussion. So, Dr. Muench, welcome.
Yeah, thank you for having me. I'm so excited to be here.
Great. Well, we're looking forward to learning a lot about this topic today. So when we talk about cancer and sleep, I know there's a lot of different cancers out there and a lot of different types of treatments even. Tell us more, what are we talking about? Are we talking about one particular type of cancer, or what are we talking about today?
Yeah, that's a really great question. I get that question a lot. So if I speak to the literature, a lot of the literature has been done in breast. We know a lot about sleep and cancer in breast, but we are expanding out to other cancers. I think that's because sometimes the funding is there for that particular cancer, but we do need to gather more information on other types of cancers. I'll also add here that it really depends on where you are in terms of treatment, right? So you can experience sleep and fatigue before you're even diagnosed. You can experience sleep problems during treatment, and you can certainly experience them into survivorship if we're dividing survivorship, after treatment has concluded.
Wow. Okay. So if breast cancer is one of the primary areas, I know, or I believe I've heard, that breast cancer is not only affecting women but can also affect men. Is that true?
Yeah, it certainly does, and it certainly can. I'll say that the research that we have in the context of breast cancer often is in women because it happens more frequently in women, but it can impact men. And I'll add here that what we do know about sleep problems outside of breast cancer and fatigue is that it can, it impacts other folks and with other cancers. The extent to which it impacts, we have some research to suggest that patients who've been diagnosed with prostate cancer might not experience as much fatigue as folks with breast or even lung cancer, but there's still more work to be done in that area. I can't say conclusively the extent at which it impacts across diagnoses.
Right. Okay. So I guess the other question I have then is, if we're talking primarily about women, are we talking about a certain age range?
Yeah, that's another great question. So we are looking, I'm conducting a study right now where I don't want to get ahead of myself, where we're using a behavioral intervention, and we are looking at age. And we also just we're publishing an abstract on this, and we are finding that folks who are over 65 seem to experience fatigue specifically more so than our younger age cohorts. The reasons for this, and you'll hear me say this a lot today, are to be determined. It could be, there's many factors when we're thinking about specifically fatigue and what may contribute to that. But we do think it happens more frequently in our older folks. But that doesn't mean that somebody who's, let's say, under the age of 65 might not experience significant levels of fatigue severely. I think sometimes context is important.
Got it. Okay. And my last initial question here before we dive in deeper is, I have had family members who have been treated for cancer, and I know we're talking about fatigue as one of the things. So when you talk about fatigue today, are you talking about fatigue because of treatment and medication, or just in general, or both?
Yeah, so I'm going to quickly define these two things. So we have insomnia, which is trouble falling or staying asleep and or waking up too early, right? So diagnostically, we say if you have chronic insomnia, it's at least 3 days per week for more than 3 months, right? But that doesn't mean that we all at some point in our lives won't experience what we call acute or short-term insomnia. And this is really in relation to a stressor, like being diagnosed with cancer.
Sure.
And oftentimes this acute short-term variety will resolve. And then we have fatigue, which is a little bit harder to measure. And the reason I say that is we do have objective measurements for sleep, right? If needed, we can send you to a lab and hook you up to what we call EEG, and we can look at your sleep staging. We can also ask you subjectively, if you're feeling drowsy, your eyes might get heavy. Fatigue is a little bit harder to pinpoint. I have this slide when I talk to patients about this that says what causes fatigue, and there's a bunch of arrows coming out from a circle, and it can be all kinds of things. One thing that we hypothesize about in cancer is that the fatigue itself and maybe even the insomnia can start before diagnosis. And so part of that is if you think about even having the flu, how do you feel before you even realize you're sick? You might start to feel tired, lethargic, but that's not quite sleepiness. And then, cancer treatment may exacerbate this fatigue. And then, I'll come back to breast cancer, hormone suppressants like tamoxifen. Anecdotally, there's not a ton of literature on this with respect to sleepiness and fatigue, but anecdotally, my patients in clinic will say that they definitely had some sleep problems, some fatigue during treatment, but it's these medications that can cause exacerbation of this symptom. So I wanted to find these things because fatigue and sleepiness can be different, although insomnia and fatigue can work in tandem together, where you have fatigue and you may do things to offset insomnia.
Right. Wow. Yeah, I can only imagine what someone going through this is dealing with, because their body is just being kind of worn down from all the things and all the worry and anxiety that naturally would come from it.
Mm-hmm.
Wow. All right, so let's get in a little deeper here, and let's talk about some of the most common sleep disturbances that patients with cancer would have and how they impact that person's quality of life.
Yeah. So like I said a few minutes ago, I think one thing that happens, right, is a cancer diagnosis is inherently and understandably stressful, right? And so you go to the doctor and you get this diagnosis and they're throwing a lot of information at you. And this is often where we see the acute short-term variety of insomnia, where you have this stress, right? Sometimes when I'm in the clinic, I'll be consulted and a patient has insomnia. And by the time they get to see me, once the plan has been laid out for treatment and they have more information and they understand what's going to happen, that insomnia resolves. Where we get into trouble is when the insomnia doesn't resolve. And so that is the chronic variety, where it's lasting really for more than 3 months. You're having trouble falling asleep for more than 3 days a week. And we know that that sleep and the immune system are intricately linked, right? And so there is some truth to, when they say go to sleep, you'll feel better in the morning. Well, get good sleep and you're going to feel better long term. It's not to say that if you don't sleep well, I've read some books and heard things, and patients have a lot of anxiety. If I don't sleep, am I going to develop chronic illness? Am I at risk for things like dementia and cancer? There's not really a ton of data that bears that out well. But I will say, if you want your immune system to work well, it's important to get good rest. So I'm often paying attention and encouraging medical providers to not send patients to me when the insomnia is chronic. Send them to me when they're starting to complain about it, so we can nip it in the bud sooner rather than later. So they're not going into survivorship with fatigue and insomnia and all of that.
Mm-hmm. So, the whole area of sleep medicine, sleep issues is relatively new compared to many other types of medicine, right?
Yes,
so
totally.
When is it that sleep medicine, or maybe we're in the early stages, when did sleep medicine become paired with cancer to even be a thing for doctors to think about?
Gosh, I love this history lesson. I give it to my students all the time. So I'm going to go back before cancer. So I'm going to speak to sleep medicine, this idea of sleep staging and all of that, and really kind of digging into this. I have some slides where you see in the turn of the last century, so, the late 1800s, there's some texts starting to come out about this. And then in the 1920s, There were some researchers and physicians who were starting to write about this. And then, don't quote me on this, I think it was the 40s that we got into sleep staging and discovering the EEG and identifying REM sleep. Now I'm going to fast forward because behavioral sleep medicine, what I practice as a clinical psychologist, really wasn't brought to the forefront until the late 1970s with Peter Horry. And this idea that chronic insomnia is a distinct disorder wasn't really discussed until a paper was published in 1987, where it was the first time someone really said, what if insomnia is distinct? And they were speaking to depression in this arena and saying, what if we treated insomnia and we saw some impact on depression? And, there was a lot of folks in the 90s and the early 2000s, including Dr. Michael Perlis, Dr. Christina McRae, Kenny Lickstein, I hope I didn't leave, I'm sure I left people out, but, those people who really did the work to say, insomnia is distinct, and it's important, not just for the behavioral reasons, but for quality of life, for things, right, like medical reasons, comorbidities, and that we should be treating it. Oh, and I don't want to leave out Charles Morin, right, who wrote the first bits of work and protocol using CBT for insomnia, which is the intervention we use and I use in cancer. And so there's a really quick kind of down and dirty about the history of this. But if you think about this, if 1987 was the first time someone formally really codified and said, hey, we should be looking at insomnia in a distinct way, it's really only been, 37 years since that time. And it wasn't until 2016 that the American Academy of Physicians came out and said, hey, we should be using CBTI as a first-line intervention. And so this is all, as you said, very new. In the context of cancer, we're not quite there yet, right? And I think part of the reason for this is if you think about cancer and everything that goes into it, from diagnosis to identifying treatment, sleep and fatigue, I'll put them in a bucket here, often get placed at the bottom of the barrel. And so it's not the primary thing that people are thinking about. And again, some of the sleep problems we see are to be expected acutely. When I educate physicians and providers and medical residents, I often say this, that we can have these conversations and also set expectation around what patients might expect. It doesn't mean that we're going to jump in and do a full behavioral treatment like cognitive behavioral therapy for insomnia, but setting those expectations are important. So we're very new here. The research is very new. So that's why you also may hear me say, it's to be determined. We're not quite sure yet.
Right. Yeah, and as you were talking about that, I was thinking to myself, just to kind of put this into perspective for the listeners, a lot of the people that Dr. Muench was talking about doing the research and working in the field, these are people that are alive and currently working in the field still. This is not, it's not old stuff.
All of these people are still alive. Yeah, so this is not old at all. And I mean, even if you think about like our prior DSMs that are diagnostic manuals, these are the manuals that we use as clinicians to diagnose mental health. Insomnia, up until fairly recently, was considered a symptom. And so this is all very new, and it's going to take some time to really get the word out and highlight the importance for our providers of addressing these things earlier within cancer and in general practice, like primary care. I mean, our primary care physicians see the bulk of the patients coming in with new insomnia.
Right. And that's, that raises another question, and it may be an unfair question to you, so tell me if it is. But on this show, because it's UK Health Radio, we deal with the US, we deal with UK, we deal with other European countries. And when I speak to doctors in the UK, I'm often told that sleep is just a primary thing that a primary care physician would naturally ask about. But when I get to the US, it's not. Yeah. Do you have any colleagues that you've worked with in terms of cancer? How does that work?
Yeah, that's a great question. In the UK, the NHS is a bit ahead of us in this regard. I often look to them and the work that they're doing for, standards when I'm educating providers. So in cancer, again, this is new. We're currently working with NIH right now to implement not just I know we're talking about sleep here and that's the focus, but general brief interventions for support for cancer, because even that is new in the US. This idea that we should have embedded professionals, not just, of course, our oncologists, our nurse practitioners, our medical professionals, but supportive staff in these clinics embedded. So this is really kind of a now new idea, although our guidelines, our NCCN guidelines state that this should be the case. Implementing it has proved a little bit more difficult. So in the context of sleep, I don't think there's many systems that have dedicated specialists who are doing CBTI or who are addressing these issues in their clinic. Now, I'm at Penn, we do, because I'm there, and I started the sleep and cancer clinic there, where my goal is to address these issues right away. And so we're building a practice where my specific focus is if your patient has sleep and or fatigue problems, send them to me and we'll address them, both in the context of treatment and into survivorship.
Wow, wonderful.
Yeah.
I'm so glad to know that exists, and I'm sure that plenty of people will be glad to hear that.
And I think Pittsburgh has it too. I want to call them. I think University of Pittsburgh might have it as well. But this is all very new and novel, and so it takes some time to kind of turn that ship.
Great. Well, this is a point where we need to take a break and do a commercial, but we will be right back with Dr. Alexandria Muench. Stay tuned. You're watching Sleep Science Today. If you enjoy our show, please help support us by pressing the like button, subscribe to our channel, and hit that notification bell. It'll really help us get seen, and it'll help you stay informed. All right, we're coming back to Sleep Science Today. I'm your host, Andrew Colsky. We are talking about sleep and cancer and fatigue today. We've got Dr. Lexi Muench. I'll call you Lexi. Is that all right?
It's totally fine.
And so let's talk a little bit about treatments. So let me ask this. How do current treatments for cancer-related fatigue and sleep disturbances compare, and what are some of the approaches that are coming out?
Yeah, so I'll start with insomnia first. So I've kind of alluded to this treatment that we have called cognitive behavioral therapy for insomnia. It is a first-line intervention for insomnia specifically. Typically 6 to 8 sessions, give or take, depending on what the patient needs. And what we know about this treatment is it's so robust. And so you can do it in many populations, including cancer. So if you are having insomnia in the context of cancer, CBT for insomnia is useful. Now, the issue with CBT, I'll call it CBTI for short, is that there aren't enough providers, right? And so this becomes the problem. It's not that it doesn't work, but it's often not available. At a place like Penn, I often say we have too many. So many people doing different types of CBTI, like myself, in special populations, but a lot of hospital systems and areas don't have it. The beautiful thing, though, is now psychologists at the very least have a thing called SciPact. So for our listeners out there, if you're in the United States and you're looking for a CBTI provider, there are resources. You can Google this, and there's folks who can do this now via telehealth across state lines. So I want to put a plug there. If you're struggling with sleep and, in the context of cancer and otherwise, please do look this up. Now we have additional ways for you to access. So I'll put a plug for CBTI. But we can do this in the context of cancer, and we know it works. We know it works in the clinic. We know from a research standpoint that it works well. Sometimes in the context of cancer, we do things a little bit differently. And part of this has to do with fatigue. And so in standard CBTI, I might not encourage napping, right? But if I have a patient who is in treatment, is getting radiation and or chemo, has had surgery, we do structured napping, right? Because they need more rest than others. For fatigue, as I said earlier, it's a little bit harder because oftentimes by the time patients come to see me, the fatigue is rolling, right? We didn't target it right away. And so I often cobble together things that I know from the research work. So I encourage patients to get a light box. You can order them on Amazon. Back in the day when I was first starting my training, they were very big. These light boxes, you had to have insurance pay for them. Now they're the size of an iPad. The reason I recommend this is because there is research to suggest that cancer and cancer treatment may impact the circadian rhythm. And what does that mean? So in sleep, we have two processes. We have our circadian process, which is our internal clock, right? It's our alerting signal in the morning. Our other process is our sleep drive, how tired we are at bedtime. That's how likely we're going to be able to fall and stay asleep. It's sleep pressure. For circadian, light is important. And so I encourage my patients to get up in the morning when they're drinking their coffee, turn on the light box, and sit about an arm's length away for about 30 minutes. There's a thing called the Happy Light, and so you can order them, and there's other versions too on Amazon. They range from like $16 to $30. And so I recommend that. I also recommend exercise. There's a lot of research, especially in the MS literature, that suggests that exercise can be really helpful for fatigue. Now, when I say exercise, I don't mean you don't have to go out and run a 5K. Even mild to like moderate levels of exercise can be useful. That can mean doing like chair exercises, light weights, stretching, just getting your body moving. And then, as I said earlier, napping. And so napping before 3 p.m. with an alarm in your bed if you can. And sometimes my patients will say, I can't fall asleep. That's okay. We're really thinking about energy conservation because cancer fatigue is different than exercise-induced fatigue, or the Merriam-Webster definition that says it's proportional to the level of activity you've done. Cancer-related fatigue is not. And so you have this again because of treatment, because of the cancer itself, because of medications. And so we really want to be intentional about how we're using our energy and taking rest during the day.
So you may have said it, and I might have missed it. When you were talking about napping, how long of a nap are you talking about, and how many times a day?
Yeah, that's a great question. So I usually say 30 to 40 minutes. So you set an alarm, and even if you aren't sleeping, you get up and out of bed or where you're laying down at that time. The reason for this is we don't want folks to go into a full sleep cycle, and we don't want to take away from the sleep drive at night. And so that's why I suggest no more than 40 minutes. A full sleep cycle is about 90. And so we also want to limit how much time you're spending in bed. And the reason I say before 3 p.m. is we don't want to bleed into, your sleep time and all of that.
Right. So I wonder, are you aware of whether or not there's been any research? Like when I think about people getting chemotherapy, which is like chemicals and medicines, and then we've got radiation treatment, which is another thing. Has anyone done any studies whether that or how that might impact melatonin production or any other sleep chemicals?
That's a great question. I'm not entirely sure about the melatonin component of this. I will say my thinking would be we do know that there is some impact on the circadian rhythm. And so if that's the case, so for your listeners out there, right, the reason Andrew is asking this is because melatonin, we make our own melatonin. I know we can also buy it at CVS, but we make our own. And so melatonin is circadian. It's a light and dark chemical. And so a couple hours before bedtime, your body starts producing melatonin just to cue up the sleep system and say, hey, we're getting close to bedtime. And so I would think that if we have some idea that the circadian rhythm is being impacted by these things, by treatment and cancer, that maybe there's some impact on melatonin.
Mm-hmm. Yeah, I was just kind of thinking about it because you have all these different chemicals and things going on throughout your system. There's got to be some impacts.
Yeah, and there's also some research to suggest that there is something going on neurobiologically with fatigue, and so I would think that maybe the sleep centers of our brain are potentially impacted. We have immune pathways in our brain, and so if we think of the immune system like a light switch, think of a dimmer. And so when you have something like cancer or another, let's say like an autoimmune disorder, your immune system is on, it's activated. And so potentially the reason why we see lingering fatigue even after treatment could be because the immune system is now activated. And so finding ways to dim it can help, like through light, through exercise, through, I can talk about this in a little bit, through using CBTI. We're finding that can be useful for fatigue, might be helpful in kind of putting on that dimmer and decreasing the activation of the immune system.
So let me think how to ask the question. If someone is dealing with fatigue, I kind of think of it as similar to someone who's dealing with depression, right? They don't have the energy to do things. And it's always a hard thing when, if I'm talking to someone with depression, they're like, well, yeah, I'd love to do those, but I can't because I don't have any energy because I'm so depressed. So how am I supposed to do these things to treat myself? Any tips or comments about what someone should do there?
Yes, 100%. It is similar. I was just in another talk yesterday. Somebody else was giving a talk about fatigue, and her focus is on sleep, patients with insomnia and fatigue, and she looks at this. And one thing that came up is this idea that, so we have our behavioral treatments, right? I am a sleep person, right? But I'm a psychologist first and foremost. And so I often use acceptance and commitment therapies for this, right? And in depression, they talk a lot about behavioral activation. But one thing, that comes up is like, well, how, like you're saying, do we behaviorally activate someone? It's easy to be like, go take a walk. And the person might say, but I can't take a walk. And
right.
So what I like to ask people to consider, right, is SMART goals. I always want goals, even in insomnia treatment, in CBT for insomnia, I want my goals to be specific. I want the goals for my patient to be measurable. I want them to be achievable. That is the most important one. I want them to be relevant and timely. And the reason why I talk a lot about SMART goals is oftentimes in the context of fatigue and cancer, it's also a role change. Life is different, right? And so if you have a cancer that is now limiting what you used to do before, that can cause depression, and which can exacerbate fatigue. So I'll give an example. I had a patient once who her role in the home, right? She stayed home with the kids and she cleaned the home while her husband was working and all of this. And that was part of how she contributed. And post-cancer, it was hard for her to even get the laundry up the stairs, right? And so, what we did was we set goals around that, right? Maybe we don't carry all of the laundry up the stairs at the same time. We're going to break it up into smaller bits that are achievable for you. And those achievable small goals can be a game changer in empowering folks, right? Your life will look different, right? And that's where we get to the acceptance piece. And when I say acceptance, I don't mean like pulling your bootstraps up and getting over it. I mean like some moving towards this idea that my life's going to look different, but it doesn't mean that it's not fulfilling. And so when we're thinking of fatigue, and I spoke to energy conservation, on a good day, I think about the pain literature on this too. On a day when I don't have fatigue, I don't want people to do the most, because what that sets you up for is feeling horrible for the next 2 to 3 days. We really want to be intentional about the activities we're doing and resting in between those activities. And that's how I think we garner success in these folks and help move towards a better quality of life.
All right, well, this is a great discussion, and I think it's a perfect time for us to take a break. So let's do our second commercial break, and we'll be right back. You're watching Sleep Science Today. If you enjoy our show, please help support us by pressing the like button, subscribe to our channel, and hit that notification bell. It'll really help us get seen, and it'll help you stay informed. All right, we're back on Sleep Science Today. We've been talking about cancer treatment and sleep. One of the last things that you had said was defining SMART goals. And, I really like that because in my practice, one of the things that I found is that when patients think about trying to achieve this huge, overwhelming goal, they just kind of shut down because it seems so insurmountable, so impossible for them to do. And so, so we break it down into very small, bite-sized pieces. And when we're talking about a bite-sized piece, like, can can you do this one little thing? It's like, oh yeah, I can do that one little thing. That's not a big deal. And then you do 10 little things, and now you've gotten to a bigger goal.
Right.
So I really like how you're using that. So putting that all together into context, we're talking about fatigue, we're talking about all these things together. What does it look like for you, or actually for a patient who's trying to access care?
Yeah, that's a great question. So as I said earlier, it's important for patients to feel like they can achieve the goals that are set, right? And in the context of cancer, all of this can feel quite overwhelming. So if I speak to fatigue, because this is really where SMART goals come into play, CBTI, we certainly set goals, but they look a little bit different. Fatigue, again, like cancer, can feel quite overwhelming and have an impact on quality of life. So when I'm setting goals with patients, we're thinking of things that are really achievable. And so we know in fatigue, especially in the context of cancer, that it's not proportional to the amount of activities you're doing or the energy you're expending. So we're thinking around creating goals that are intentional, that allow for energy conservation. Taking breaks throughout the day is really important, which can be hard. And, what comes up here is role changes, right? When you're used to your life looking a certain way. So the SMART goals here really around protecting our energy, being intentional about the energy we expend, and making sure to keep those breaks throughout the day so our energy can maintain until bedtime.
So, excuse me, we talked a little bit last segment about how, people don't have the energy to do certain things that they'd like to do, but then at certain times they do have the energy, and you said that it was important that when they have the energy not to overextend themselves, because then they wear themselves out.
Yes. Yeah, totally. Yeah, so on a day, I don't love to use the term good days and bad days, but if you take a day where fatigue isn't as impactful and you're feeling better, it can be enticing to go out and do all of the things, right? And, even it can be things like chores and going to the grocery store. And all of those things obviously need to get done. But again, it's really about pacing ourselves. And this could be said for society as a whole, right? There is this concept in sleep around social jet lag. And hustle culture. And so I really encourage everyone who's listening in cancer and otherwise to be intentional about how we're expending our energy and how we're using that time throughout our day so we can feel better and more rested and feel like on all of our days that we can get things done and not feel so burnout. Yeah.
So if someone is recently diagnosed with cancer, so it's all new to them. Obviously, it's going to be a devastating thing for them to hear, and it's going to take time for them to process it and work through it, and family members as well.
Yeah.
And we're saying that the earlier they can start addressing sleep issues, the better. And I can certainly understand that someone might say, well, that's the least of my worries right now,
yes,
right?
Totally.
But once things kind of settle and they're starting to kind of put the whole plan together for treatment and what it's going to look like and how to go forward, and maybe even a family member would be the one to do this, maybe a husband or a wife or something like that. How should they go about setting themselves up to address this issue? Should they wait for their doctor to tell them to do it, or should they bring it up themselves, or what's the process?
Yeah, that's a great question. So I always encourage my patients to be their own advocate because, doctors, physicians, medical teams are human too, and especially in cancer, there's a lot of things to check off, right? And when we're seeing our medical oncologist or the hemonc team, it might not be a priority in their checklist, right? Because there's other things that they're attending to in the visit that you're having with them. So if you're having a sleep problem or you're starting to experience fatigue that, whether it's minimal or it's impacting your quality of life, I encourage everyone to tell their docs, right? Tell the medical teams, tell the nursing staff, because there's ways in which that, if they know about it, that they can be helpful. So I think that's the first step, because if you aren't telling your doc, it's hard for them to know what to do. And other teams like palliative can be in looped. Someone like me, a person who's in the behavioral sleep medicine field can come in if that's available. And if not, there's also apps that are accessible, right, that can be useful, self-help apps and things like that. But I think it's always best to have the conversation with your doctor. There might be something else going on too. Maybe you have low iron or low vitamin D and they can do blood work. So telling your doc is always the first step.
Mm-hmm, mm-hmm. So help me understand then a little bit more about kind of what I'll call sort of the boots on the ground part of it. Meaning, so you have a conversation with your oncologist, and your oncologist says, we really ought to set you up for proper sleep care as well, and dealing with potential fatigue that's coming. Is that like another appointment? They have to go into your office and talk to you? Do you come to them? Do they just work with the oncologist?
That's a great question. So the ideal scenario would be somebody like me would be embedded in a clinic, and there's certain, whether it be oncology, so I'm what they call a psycho-oncologist. My job is related not just to sleep, but to helping patients who have or who've had cancer manage any distress around it. And ideally, places like MD Anderson often have that embedded, but that's not the case everywhere. So in my clinic, patients are referred to me. I'm a telehealth mostly clinic to make it more accessible to folks. But there's other, settings where maybe you set an appointment, you go outpatient in person. It really depends on the way this is set up. And, to be honest, and I think I spoke about this earlier in our conversation, if these services are available, not all medical systems have, social work, psychology, behavioral sleep medicine in their system. So it's about, knowing that the services can exist, asking your medical team, and maybe also doing some research too, which can feel overwhelming for patients. But we are trying to roll this out in various clinics, like at Penn.
Mm-hmm, mm-hmm. Fantastic. I'm glad that it's getting out there, and I'm glad that you're really sort of one of the pioneers of making this happen. And that's
we're trying. It's a big sleep and fatigue is a big problem in cancer. So my hope is that 20, 30 years from now, maybe sooner, this is I'm able to come and say, this is standard of care.
Right. So then let's talk about one other thing here, which is, if somebody knows that they are going to be going through cancer treatment, is there anything that they could or should do up front to set themselves up to avoid as much as possible the fatigue and things? And I'm talking about anything from physical things to prepping their actual bedroom. What type of tips do you have?
Yeah, so the one thing we know is, and I may have said this earlier, is that there is acute insomnia, right, short term, and there's the chronic variety. And we all have short-term acute insomnia at some point in our lives. It's directly related to a stressor. It does not mean you're going to develop chronic insomnia. Chronic insomnia is maintained by spending extra time in bed while awake, pairing the bed with wakefulness. And so what I encourage folks to do, because sometimes I see folks for one session where they're having acute insomnia, and I do some education around this, is try not to spend extra time in bed, right? So that means go to bed when sleepy. If you're not sleepy, get up and out of bed and go to another room or another space in your room if you're able to do that. Don't go back to bed until you're sleepy. It may mean that you're awake in the middle of the night, but the majority of the time, that's okay. You might be a little bit tired the next day, but provided you're not driving and you're able to feel safe in that capacity, the next night you'll increase your chances of falling and staying asleep. With respect to fatigue, right? Light is super important. So getting light in the morning, getting a light box, like a happy light, which you can get on different platforms. Exercise, even if it's something like chair yoga or lifting light weights, staying active, structured napping, can be useful too. So, napping in bed without an alarm. And also, like I said, energy conservation, being intentional, especially during treatment, about how you're expending your energy and taking time to rest. So, again, life might not look like it did before treatment and before cancer. And that's another thing that someone like me, like a psycho-oncologist, can help patients manage. But engaging in energy conservation will be a game changer for folks, if possible.
Yeah, and I'm thinking about this myself as well, and I guess another thing in there would be that if your bedroom has clutter and things like that, if you can clear that beforehand, because you're not going to have the energy to easily get in and out of bed, I'm assuming.
Yeah,
and you don't want to fall.
Sure, yeah. So yes, if there's any issues with ambulatory issues or trouble walking or that type of stuff, yeah, making a pathway for yourself, if you can, making the bedroom a calming, relaxing space. Blackout curtains are really great to prevent light from coming in. Those types of environmental factors, making sure your room is dark and cool, and comfortable is always a benefit. Nice sheets. I'll also put a plug in for, there's devices. So for folks who have induced menopause from cancer, or breast cancer folks, and in that vein, there's something called the bed jet that cools the bed from underneath. If we think of fans, they cool top down, but when you're having hot flashes, they can cause sleep fragmentation and be quite disruptive. So there's, bed jet is one that comes to mind. I'm not being sponsored by them, but a lot of my patients like this device because it's cooling from underneath and it can help mitigate hot flashes.
Right.
Or help manage them,
Right. All right. Well, we are actually out of time for the day. So I want to thank you. This is Dr. Alexandria Muench. She is working with cancer and behavioral sleep medicine at University of Pennsylvania. And we appreciate all the information, and we hope to have you back with some good news stories as your clinic grows.
Thank you so much for having me.
Thanks.
Thank you for listening to Sleep Science Today and learning how to sleep better with your host, Andrew Colsky, on UK Health Radio. For more information on how you can achieve better sleep, go to sleepsciencetoday.com. Remember, sleep science today and sleep better tonight.